We're undertaking a critical and, let's be honest, incredibly dense mission, a deep dive into the chemotherapy of neoplastic diseases.
It's the ultimate high-stakes pharmacology. We're looking at a stack of sources that detail the very foundations of modern cancer treatment, how these powerful drugs work, how they're classified, and, maybe most importantly, the strategies needed to use them without fatally damaging the patient.
When you look at the historical context here, it's just amazing how young this field is. I mean, we're not talking ancient remedies.
Not at all.
Modern treatment for malignant disease only really kicked off in the 1940s. And it originated, rather grimly, from research into chemical warfare agents.
That's right. Specifically, the introduction of nitrogen mustard. That was the starting gun.
And since then, the progress has been, what, exponential?
Absolutely. It's been driven by two things. Discovering new agents, of course, but also achieving just profound biological insight. We've moved from what was really a brute force approach of cellular damage to understanding specific growth factors signaling pathways.
And even the process of new blood vessel formation, which is angiogenesis, right?
Angiogenesis, exactly. And the result of all that progress is that when an oncology specialist develops a plan today, they are not aiming blindly. The sources lay out three very distinct core goals for chemotherapy, and they really dictate the entire course of treatment for you, the patient.
So let's talk about that first goal, the most optimistic one.
That would be cure or prolonged remission. For certain malignancies, chemotherapy is the primary definitive modality. We're talking about acute leukemias, Hodgkin's disease, Wilms's tumor.
That's a kidney cancer in children, I believe.
It is. Also rhabdomyosarcoma and testicular teratomas. In these cases, the regimen is designed from the ground up to be curative, maximizing drug exposure to, hopefully, eliminate the disease entirely.
Okay, so that's the home run. But the second goal, palliation, is arguably more common, and it requires a very different mindset.
A very different mindset. Palliation means shrinking tumors and alleviating the debilitating symptoms, the pain, obstruction, weight loss that come with the disease.
So here you might not be going for a complete cure.
Exactly. Palliation is typically the goal in less sensitive but more common solid tumors like breast, ovarian, colon, and small cell lung cancer. The treatment might not eradicate every last cell, but if we can significantly improve the quality of life and the duration of survival, well, that's a successful outcome. It's pragmatic medicine.
And then there's a third strategic aim, adjuvant therapy. I think this is kind of the unsung hero of modern oncology.
I agree with that.
This is chemotherapy used after the main event, after surgery or radiation, to eliminate what our sources call micrometastases.
And those are just residual malignant cells that might be circulating or, hiding out somewhere. They're too small to be detected by scans, but they're still capable of seeding a relapse down the road.
So the adjuvant approach is purely preventative.
It is. It's mopping up, essentially guaranteeing that any lingering enemy cells are dealt with before they can mount a resurgence.
It's clear that this kind of biological warfare demands just incredible sophistication. The key principle woven through all the source material is that no one tackles this alone.
Oh, absolutely not. Effective cancer management is inherently a function of oncology specialists leading a highly multidisciplinary team. You need the surgeon, the radiologist, the pharmacist, the medical oncologist.
Yeah.
Everyone coordinating the attack.
Okay, so let's unpack this core tension. Chemotherapy works because these drugs are cytotoxic. I mean, they kill cells or profoundly modify their growth. But the fundamental dilemma, the double-edged sword, is that their selectivity is, well, it's painfully limited.
That is the essential, unavoidable challenge. Chemotherapy is based on the principle that the most profound effect of these drugs will be exerted on rapidly multiplying cells.
And why is that?
The primary reason is that the main target is nucleic acids, so DNA and RNA and their precursors, which are all undergoing rapid synthesis during cell division.
So the idea is that cancer cells, which have a high growth fraction, meaning a large percentage of their cells are actively dividing at any given time, they're just significantly more susceptible than most normal cells.
They are more susceptible, yes, but not perfectly targeted.
Yeah.
The fundamental flaw is that our normal body tissues that rely on constant rapid renewal get caught in that metabolic crossfire.
And you mentioned those tissues before, and they really do bear repeating because they dictate the patient's entire clinical course.
They do. We're talking about the bone marrow, the lining of the gastrointestinal tract, the cells in hair follicles, and the reproductive cells in the gonads.
So when we talk about toxicity, we are really discussing the necessary, unavoidable cost of damaging those normal, rapidly cycling tissues.
And the absolute most serious toxicity, the one that is often the dose-limiting factor, is bone marrow depression, or BMD.
Hmm.
It's a dose-dependent suppression, and it affects all three major cell lines.
Red blood cells, white blood cells, and platelets.
All three.
So let's break down the clinical reality of that. When we talk about low white cell counts, specifically granulocytopenia, we're talking about wiping out the patient's primary defense mechanisms.
Yes. And that doesn't just increase infection risk. It makes the patient highly vulnerable to any bacteria or virus. It often requires extreme isolation and constant monitoring.
And if we're talking about low platelet counts or thrombocytopenia, that's bleeding.
Right.
Right.
That's life-threatening bleeding complications.
Yeah.
The oncology team has to constantly walk this incredibly fine line. Use enough drug to kill the tumor, but not so much that the resulting BMD leads to a fatal infection or a hemorrhage.
And anemia from low red cells.
Anemia is also present, but it's usually less immediately life-threatening than the neutropenia and the thrombocytopenia.
You also noted the injury to the lymphoreticular system, causing lymphocytopenia and suppression of cell-mediated immunity. Wait, that sounds particularly severe. What does that tell us about the patient's immune status?
It tells us the patient has advanced immunosuppression. While humoral immunity, that's antibody production, often remains somewhat intact, suppressing cell-mediated immunity just opens the door for opportunistic infections, the kind you usually only see in patients with profound immune deficits.
And the sources list the big concerns here.
They do. Fungal infections like deep mycosis caused by candida, viruses like herpes, and protozoa like pneumocystis cerevisiae and toxoplasma.
Pneumocystis, that's a huge flag. That just highlights how completely broken the immune system is during treatment, doesn't it?
It really does.
Yeah.
It means the treatment regimen isn't just about administering drugs. It's about constant prophylactic antibiotics and antifungals to cover all these gaps. It's an ongoing fight just to keep the host alive while the cytotoxic agents are doing their work.
Okay, so beyond the systemic threats, the damage to the epithelial linings is intense.
Almost universal. The gastrointestinal and oral impact is huge. The oral cavity is highly susceptible because of its high epithelial cell turnover. Drugs like methotrexate, doxorubicin, actinomycin D, they frequently cause stomatitis.
Painful mouth ulcers and sores.
Yes, and it's often one of the first and most distressing signs of toxicity for the patient.
And the entire GI tract suffers too. The mucosal lining is constantly renewing itself, so cytotoxic damage causes severe diarrhea, sometimes compounded by hemorrhages and infection.
Right. And diarrhea isn't just discomfort. It can lead to massive fluid loss, electrolyte imbalances, and if you couple that with neutropenia, it can turn into a deadly septic infection that originates in the gut.
And then we have to acknowledge the immediate practical reality that often just sabotages patient compliance. The emetogenic potential. The power of the drug to induce severe nausea and vomiting.
This is caused by both direct irritation of the GI tract and central stimulation of the brain's vomiting center.
And to manage this, clinical oncologists have to know the severity profile of every single drug they use. We have the classification right here in the sources, and it dictates the prophylactic antiemetic regimen.
It does. The high-risk group includes drugs like cisplatin, mustine, cyclophosphamide, and actinomycin D. These will almost certainly cause debilitating vomiting without powerful intervention.
Then you have the moderate group, which still demands strong antiemetic protocols. That includes carboplatin, procarbazine, doxorubicin, ifosfamide, methotrexate, and paclitaxel.
And finally, the mild group, like bleomycin, fluorosil, etoposide, and L-asparaginase.
And the fact that L-asparaginase is considered mild really shows you the scale we're dealing with here.
It really does.
How far have modern antiemetics like the 5-HT3 antagonists ondansetron and its cousins actually moved the needle on compliance?
Well, they've been revolutionary. I mean, before the widespread use of these targeted antiemetics, high-dose chemo often meant multiple days of constant severe nausea and vomiting. It severely impacted hydration, nutrition, and mental health. Now, while it's still challenging, we can manage the nausea proactively, allowing patients to tolerate highly aggressive and curative regimens.
Okay, let's quickly run through the other major costs, alopecia or hair loss.
Common due to damage to hair follicle cells, but this is usually reversible. More concerning is the impact on the gonads. The inhibition of gonadal cells causes infertility oligozoospermia in men and amenorrhea in women.
And for young patients facing curative regimens, that's a permanent decision they have to make.
It is, and the profound danger here is damage to the germinal cells, the sperm and egg precursors, which can result in genetic mutations. For women who are pregnant or planning to be, the message is absolute. All cytotoxic drugs are highly dangerous to a developing fetus.
causing abortion, fetal death, or teratogenesis. It's an absolute non-negotiable contraindication.
Absolutely. And finally, a metabolic complication. Hyperuricemia. This happens when massive cell destruction, sometimes called tumor lysis syndrome, releases a sudden flood of cellular contents, including purines, which are then metabolized into uric acid.
And you see this most often in leukemias and tumors with large rapid bulk.
Right, and if that uric acid precipitates in the urinary tract, it can cause acute renal failure, which is a life-threatening complication in an already fragile patient.
So the counter strategy is built right into the treatment protocol.
It has to be. We administer allopurinol proactively to reduce uric acid synthesis and prevent this complication, especially when we're using drugs known to cause rapid cell kill.
Okay, so now we pivot from the general destruction to the highly specific molecular strategies. We've established the price, now let's analyze the weapons. We're going to organize the major cytotoxic classes based on how they interrupt the cellular life cycle, starting with those that directly attack and physically damage the DNA structure itself.
Yes, and we can start with the alkylating agents. If we're using an analogy, these are the heavy-duty chemical welders.
Chemical welders, I like that.
What's fascinating here is their core mechanism. They generate these highly reactive carbonium ion intermediates. These intermediates then transfer alkyl groups to vital cellular macromolecules, forming strong, permanent covalent bonds.
And the primary target for this welding is the N7 position of guanine residues in DNA. So you're essentially jamming the machinery by sticking chemical groups where they just don't belong.
Exactly. And this action is devastating because it leads to three major DNA flaws. First, cross-linking, which tethers the DNA strands together. Second, mispairing of bases during replication. And third, strand scission, or just breaking the backbone. They render the DNA unreadable and impossible to repair.
And their operational profile is key here. They are cell cycle nonspecific CCNS.
Right. They affect cells at all stages, G0, G1, S, G2, M, and even resting cells. But they're particularly effective because the damage they inflict becomes lethal when the cell then tries to divide.
So let's talk about the original group, the nitrogen mustards.
The highly reactive mechlorethamine is mostly relegated to topical use for skin lymphomas now, but the true workhorses are the less reactive analogs: cyclophosphamide, aphosphamide, and methylone.
Cyclophosphamide seems to be the superstar here, used against everything from lymphomas and multiple myeloma to breast and ovarian cancer.
It has a very broad range of activity.
But as we mentioned earlier, it comes with that severe dose-limiting toxicity, hemorrhagic cystitis, that painful bleeding bladder inflammation, and potential neurotoxicity.
And this is a perfect example of modern chemical engineering saving the day. The bladder toxicity is caused by an excretory metabolite called acrolein. To prevent this, we have to co-administer mesna.
Mesna. And what is that doing?
It's a protective SH sulfhydryl compound that's concentrated in the urinary tract, where it chemically detoxifies acrolein before it can damage the bladder lining. Evosavide carries the same risk and requires the exact same strategy.
So the administration of cyclophosphamide is actually a two-drug chemical system designed to keep the patient safe while the active metabolite goes to work on the tumor. That's really elegant.
It is. Next, you have the nitrosurias, like carmustine and lomustine. Their specialty is their chemistry. They're highly lipid-soluble.
Which is crucial because it allows them to penetrate the blood-brain barrier.
Exactly, and that immediately makes them indispensable for specific, hard-to-reach malignancies like meningeal leukemias, primary brain cancers, and brain metastases. Most cytotoxic agents just can't touch those areas because the BBB locks them out.
And what about busulfan?
Busulfan is an alkyl sulfonate. It stands out because of its extreme selectivity for myeloid elements, the precursors of white and red blood cells.
Which makes it primarily useful for what?
For the palliative treatment of chronic myeloid leukemia, or CML, you use it to gently suppress the overproduction of granulocytes. Its unique toxicity is the risk of pulmonary fibrosis, a chronic progressive scarring of the lungs, and also skin pigmentation.
Okay, moving to the platinum coordination complexes. We're still in the realm of direct DNA damage, but now we're using heavy metal chemistry instead of alkyl groups.
That's right. They essentially form reactive moieties that cause both intra- and interstrand cross-linking in the DNA. They disrupt the helix structure in a way that's chemically analogous to alkylating agents, inserting a massive kink in the DNA backbone.
And cisplatin is the foundational compound here, essential for ovarian, testicular, and bladder cancers.
But as you noted, it's infamous for being highly emetic, and its primary dose-limiting toxicity is nephrotoxicity acute renal impairment.
So how do you manage that? The clinical strategy must be a logistical nightmare.
It is. Because it's so toxic to the kidneys, it absolutely requires aggressive pre- and peri-treatment strategies. You have to give a large volume normal saline infusion before the drug is administered, sometimes up to 3 liters.
To hyperhydrate the patient.
Right, to hyperhydrate them and flush the kidneys rapidly, which minimizes the drug's contact time with the renal tubules. This complex management is just non-negotiable.
It also carries risks of neurotoxicity, particularly hearing loss or ototoxicity, and that frightening potential to induce a shock-like state due to electrolyte shifts.
Which is why the second-generation compound, carboplatin, was developed specifically to mitigate these side effects. It's better tolerated, with significantly less nephrotoxicity and neurotoxicity.
But there's always a trade-off, isn't there?
Always. We simply traded one dominant toxicity for another. Carboplatin carries a much higher risk of thrombocytopenia, that is, platelet count depression. The choice between cisplatin and carboplatin often comes down to the specific regimen and the patient's baseline kidney function versus their bone marrow reserve.
And the third generation, oxaliplatin. What's the strategic advantage here, beyond just being a newer compound?
Oxaliplatin often works against tumors that have acquired resistance to cisplatin. Its unique toxicity profile is fascinating. It causes a sensory peripheral neuropathy that is acutely triggered by exposure to cold.
Exposure to cold.
Yes. Patients may feel sudden, intense pain or numbness just from touching a cold surface or drinking a cold beverage. This is a critical piece of patient counseling before they leave the clinic.
Okay, we've discussed the chemical welders. Now let's pivot to the ultimate molecular deception, antimetabolites. These are structurally similar to normal cellular components, the nucleic acid bases and coenzymes, but they're functionally useless or inhibitory.
They win by deception. They either mimic a normal metabolite and irreversibly inhibit a vital enzyme that's necessary for building DNA and RNA, or they get physically incorporated into the new DNA or RNA molecule, rendering the finished product dysfunctional.
And this leads to their key kinetic profile. They are generally cell cycle specific, CCS, meaning they are most lethal to cells primarily in the S phase.
The DNA synthesis phase. We have to start with the pioneering agent, the folate antagonist, methotrexate, MTX.
Okay, so MTX inhibits dihydrofolate reductase, or DH phrase.
Right. This is the enzyme that converts folic acid into the required active coenzyme, tetrahydrofolic acid, or THFA. Without THFA, the cell cannot perform essential de novo synthesis of purines and thymidylate. You just halt DNA synthesis at a critical upstream checkpoint.
And the ability to use MTX at extremely high doses is a strategic advantage, especially in conditions like osteogenic sarcoma.
But at those concentrations, it is also lethal to normal cells. And this is where the concept of leucovorin, folinic acid rescue, becomes absolutely crucial.
This is a chemical race against time, isn't it?
It is. The patient is hit with a massive lethal pulse of MTX. Then, hours later, you administer leucovorin. Leucovorin is essentially preformed THFA.
So it bypasses the block.
It bypasses the block. And because normal cells have better transport systems and can utilize leucovorin more quickly than many tumor cells, you're giving the normal tissue a temporary essential lifeline. It allows them to recover while the MTX pulse finishes off the tumor cells.
Let's move to the purine antagonists like mercaptopurine, 6-MP.
They inhibit the synthesis of inosine monophosphate, blocking the raw materials needed for RNA and DNA. 6-MP is a cornerstone for maintaining remission in acute childhood leukemia.
And here is a clinical detail that just emphasizes the need for that multidisciplinary team.
The allopurinol interaction.
Exactly. 6-MP's metabolism is profoundly inhibited by allopurinol, the drug we just discussed for hyperuricemia. If a patient is taking allopurinol, the dose of 6-MP must be reduced, typically by 50 to 75%.
Or they will experience catastrophic bone marrow failure. That is a critical and potentially fatal pharmacokinetic interaction.
Finally, the pyrimidine antagonists led by 5-fluorouracil, 5-FU.
5-FU is metabolized into a compound called 5-FU-DUMP, which irreversibly inhibits thymidylate synthetase, or TS. Since TS is essential for synthesizing thymine, this inhibition causes a phenomenon known as thymineless death.
And 5-FU is a workhorse against common solid malignancies, colon, breast, gastric cancer. But the pharmaceutical field has gotten clever with it. We now have capecitabine.
Capecitabine is a masterclass in selective delivery. It's an orally active prodrug designed to be converted into 5-FU, primarily inside the tumor cells themselves.
How does it do that?
It leverages high levels of an enzyme called thymidine phosphorylase, which is often overexpressed in many solid tumors. This results in a higher concentration of the active drug right at the cancer site, hopefully minimizing systemic toxicity.
And lastly, in this group, cytarabine, Ara-C, used mainly for leukemias.
This drug works by inhibiting DNA polymerase, effectively shutting down the replication machinery. It must often be administered via continuous infusion over several days because it is so rapidly deaminated and excreted by the body.
Okay, here's where it gets really interesting. We've talked about the chemistry, the welders, and the deceivers that interrupt nucleic acids. Now, let's look at agents that physically disrupt the cell's internal scaffolding and the enzymatic machinery that's responsible for organizing its vast amounts of DNA.
These agents are the ultimate structural disruptors. They specifically target tubulin, the protein subunits required to build microtubules.
And microtubules are essential for forming the mitotic spindle, the structure that separates chromosomes during cell division.
Correct. So disrupting them leads to cell arrest in the M phase, or mitosis. If the cell can't separate its genetic material, it stops dividing and rapidly commits to cell death.
The first major group are the vinca alkaloids, derived from the Madagascan periwinkle.
Vincristine, vinblastine, and vinorelbine. And they're classic examples of how toxicity profiles guide combination strategy.
Let me make sure I follow that distinction because it's vital for the listener. Vincristine is famous for causing neurotoxicity neuropathy that manifests as pain, tingling, or even motor weakness like foot drop. So why is it used so much?
Because while it causes significant neurotoxicity, it causes less bone marrow depression than many other agents. This allows us to pair it with drugs that are highly myelosuppressive like doxorubicin without compounding the bone marrow damage and pushing the patient into lethal neutropenia.
Okay, so conversely, vinblastine is known for greater bone marrow depression, but it's less neurotoxic.
Exactly. It's a strategic choice based entirely on the existing regimen and which toxicity we need to avoid stacking up.
And the second major class, the taxane, paclitaxel, and docetaxel, they work on the same target, microtubules, but with a distinct mechanism.
They do. Vinca alkaloids prevent the spindle from assembling. Taxanes, on the other hand, stabilize the microtubules, preventing them from depolymerizing or breaking down.
So they create a functional blockage by stabilizing the structure too much. The result is these rigid, non-functional bundles of microtubules that still cause M-phase arrest.
Precisely. Paclitaxel is highly effective, especially in breast and ovarian cancers. The main clinical challenge isn't just its general toxicity, but the high risk of hypersensitivity reactions during infusion.
Which requires prophylactic pretreatment?
Yes, with powerful corticosteroids and antihistamines to prevent a potentially life-threatening reaction.
And what about the unique combination drug, estromastine? It's a nitrogen mustard and an estradiol hormone combined.
It's designed to have a dual action. It acts as an alkylating agent, but the estradiol component also helps direct it, and it importantly binds directly to beta-tubulin, interfering with microtubule organization. This dual mechanism makes it specifically valuable in prostate cancer.
Okay, next group. For these, you have to think about DNA like a massive, coiled-up telephone cord.
That's a good analogy.
Every time you need to access a specific segment, you have to unwind and rewind the cord. The topoisomerase enzymes are the cellular machinery that manages this supercoiling.
Right, they create temporary breaks to relieve tension, and then they reseal them.
So these inhibitors are designed to jam that mechanism while the strand is broken.
Yes. The inhibition prevents the resealing process, causing irreparable strand breaks, which leads to cell death in the S or G2 phase.
And we have two main enzyme targets.
We do. Topoisomerase 2. Inhibitors, like etoposide, target the enzyme that manages double-stranded breaks. Etoposide causes DNA double-strand breaks and is a mainstay in testicular tumors and lung cancer.
Then there are the topoisomerase I inhibitors, such as topotecan and irinotecan, and these target the enzyme that manages single-strand breaks. Irinotecan is a prodrug, primarily active against colorectal cancer.
And the clinical application of irinotecan provides a perfect snapshot of how personalized medicine is emerging in oncology. Irinotecan is metabolized to its highly active and highly toxic compound, SN38.
And the detoxification process requires a specific enzyme.
The UGT1A1 enzyme. And here's the insight. A significant portion of the population carries a genetic defect in that UGT1A1 enzyme, which means they clear the toxic SN38 much more slowly.
So for these individuals, the standard dose is...
It can be lethal. It results in severe diarrhea, neutropenia, and thrombocytopenia. The sources highlight that many centers now routinely perform genetic testing for the UGT1A1 status before prescribing irinotecan, allowing oncologists to personalize the dosage and avoid catastrophe.
Let's move to the cytotoxic antibiotics. The most powerful group here are the anthracyclines doxorubicin, daunorubicin, and epirubicin. These are absolutely critical drugs, but they carry one of the scariest dose-limiting toxicities.
Their mechanism is complex. They intercalate, meaning they physically force themselves between the base pairs of the DNA strands.
Like putting sticky gum in a zipper.
That's a great way to put it. It blocks replication and transcription. They also inhibit topoisomerase to second and generate damaging free radicals.
But the shadow hanging over them is their dose-related and cumulative cardiotoxicity.
Yes. The major long-term concern is delayed congestive heart failure, CHF, which is severe and often irreversible.
And because this damage is linked to the cumulative lifetime dose of the drug, that risk dictates the maximum amount a patient can ever receive.
It does. And to mitigate this, we can use dexrazoxane, an iron chelating agent, which is infused before doxorubicin to protect the heart against this cumulative oxidative damage without compromising the drug's anticancer effect.
Next, bleomycin.
Bleomycin is a glycopeptide mixture that causes DNA strand scission, and it requires chelation with copper or iron. It's highly effective against testicular cancer and Hodgkin's lymphoma.
And its unique dose-limiting toxicity is pulmonary fibrosis.
Right, irreversible scarring of the lungs. The sources emphasize that while many drugs cause bone marrow suppression, bleomycin spares the bone marrow but targets the lungs.
Which means, in combination regimens, it allows the oncologist to hit the tumor harder without pushing the patient into fatal neutropenia.
Precisely.
Now let's discuss the outlier. L-asparaginase, LASPA. This isn't an inhibitor or a physical disruptor, it's an enzyme.
And LASPA is used exclusively for lymphoblastic leukemia, and it highlights a specific metabolic vulnerability. Unlike most normal cells, many leukemic cells lack the ability to synthesize the amino acid L-asparagine.
So they have to scavenge it from the bloodstream.
Exactly. So, by administering LASPA, you are essentially starving the leukemic cells by breaking down all the circulating L-asparagine into aspartic acid and ammonia. It's a resource depletion strategy.
But because LASPA is a large foreign protein, often derived from bacteria, it's highly antigenic.
Which means the major adverse effect is severe hypersensitivity reactions, ranging from chills and fever to potentially fatal anaphylaxis, requiring very careful observation and management.
And finally, the unique combination treatment for acute promyelocytic leukemia, or APL.
This involves arsenic trioxide and tretinoin. Tretinoin, a retinoid, acts by causing the immature leukemic cells to differentiate and mature, while arsenic trioxide induces cell death. It's a remarkably effective targeted treatment for a very specific subtype of leukemia. So while the traditional cytotoxic agents remain the backbone of many curative regimens, the true paradigm shift in oncology really centers around targeted drugs. This research focuses on identified targets, specific proteins, receptors, or enzymes that drive carcinogenesis.
This aims for precision. It's about reducing the collateral damage we spent so much time detailing. These drugs are potentially much more selective than the broad cytotoxic agents because they only engage the machinery specific to the tumor cells.
And the breakthrough example that just fundamentally changed the field is the BCR-ABL tyrosine kinase inhibitor, TKI, imatinib. This was the first truly successful selective targeted drug for chronic myeloid leukemia, CML.
Right, because CML cells express an abnormal, constantly active enzyme, the BCR-ABL tyrosine protein kinase.
And imatinib is a small molecule designed to slot perfectly into the active site of that specific enzyme and just switch it off. It stops the uncontrolled proliferation, leading to high rates of durable remission in CML. It proved the concept of truly targeted therapy was viable.
But the tumor cells adapt. Resistance inevitably emerges.
It does, often through mutations in the BCR-ABL enzyme that prevent imatinib from binding. This led to the development of second-generation TKIs like nilotinib and dasatinib, which can bind to the mutated enzyme and are effective against resistant CML.
Next, we look at inhibitors of the EGF-HER receptor. Epidermal growth factor receptors, especially HER2, are often overexpressed in tumors and are key drivers of growth signaling. Blocking this pathway is critical.
And we have two chemical strategies here that illustrate the versatility of drug design. First, the small molecules like gefitinib and erlotinib.
These are orally active.
Orally active, and they easily cross the cell membrane to block the tyrosine kinase activity inside the cell where the signal is processed. They're often used for non-small cell lung cancer.
And the second strategy is the monoclonal antibodies, MEs, like trastuzumab and cetuximab.
These are large injectable antibodies that cannot cross the cell membrane. They bind to the extracellular domain of the receptor HER2, or EGFR, disrupting the signal from outside the cell. Trastuzumab, for example, is highly effective against HER2 overexpressing breast cancer.
And monoclonal antibodies are also critical in blocking angiogenesis.
Right, the growth of new blood vessels that solid tumors need to survive. The key signaling protein here is VEGF, vascular endothelial growth factor.
And we have inhibitors like bevacizumab and sunitinib.
Bevacizumab is a MA that binds directly to VEGF-A in the circulation, preventing it from ever reaching the blood vessel receptors and initiating growth.
But blocking such a fundamental physiological process must come with serious side effects.
It does. Increased risk of hypertension, internal hemorrhage, and thromboembolism, or blood clots. Sunitinib is a small molecule TKI that inhibits multiple receptors related to angiogenesis, including both VEGF and PDGF receptors.
Let's discuss proteasome inhibitors, represented by bortezomib. This mechanism is truly unique, targeting the cellular waste management system.
Think of the proteasome as the cell's complex trash compactor or recycling plant. It breaks down unneeded or damaged proteins.
And bortezomib blocks it.
It blocks the proteasome, preventing it from functioning. So by jamming the compactor, you get a toxic buildup of proteins inside the cell, which then prevents the breakdown of pro-survival pathways, like the transcription factor NFKB, and that ultimately triggers cell death.
And this is highly effective for multiple myeloma.
Extremely. The cancer's plasma cells are rapidly producing large amounts of protein, so they're acutely sensitive to this disruption of their recycling mechanism.
And finally, another critical MAB, the CD20 inhibitor, rituximab.
Rituximab is a chimeric antibody that targets the CD20 antigen found specifically on B-cell lymphomas and chronic lymphocytic leukemia cells. Once it's bound, the antibody tags the cancer cell for destruction by the host immune system.
Through mechanisms like ADCC and CDC.
Antibody-dependent cell cytotoxicity and complement-dependent cytotoxicity. It turns the patient's own immune system into an executioner.
Okay, now hormonal drugs. This is a different approach entirely. They are not intrinsically cytotoxic.
No, they modify the growth environment, and they're used primarily for suppression or palliation in hormone-sensitive cancers.
Like glucocorticoids, prednisolone, and dexamethasone?
They're essential adjuncts. They have a direct lympholytic action, meaning they kill lymphocytes, so they're useful in leukemias and lymphomas. They're also crucial for controlling secondary effects like brain edema, hypersensitivity, and cytotoxic drug-induced nausea.
And for estrogen-sensitive breast cancer, the strategy is twofold. First, SERMs, selective estrogen receptor modulators, like tamoxifen.
Tamoxifen blocks estrogen effects on the tumor cells by acting as an estrogen receptor antagonist in the breast, while it can potentially act as an agonist in other tissues like the bone.
And the second approach?
Using aromatase inhibitors like letrozole and anastrozole. They block the aromatase enzyme, which is responsible for synthesizing estrogen, primarily in postmenopausal women.
So by blocking synthesis, you dramatically reduce the total circulating estrogen.
You starve the tumor of its necessary growth signal. These are often used as first-line treatment or secondary prevention in postmenopausal women.
And for androgen-dependent prostate carcinoma, the strategies mirror the estrogen approach. We use anti-androgens like flutamide and bicalutamide to antagonize androgen action directly on the tumor cells.
Or we use GnRH analogs like leuprolin and goserelin. These work by initially stimulating and then chronically suppressing the release of pituitary gonadotropins, FSH and LH,
which effectively shuts down the testicles' production of testosterone,
resulting in what's known as chemical castration.
So what does this all mean for the oncologist drawing up a treatment plan? I mean, we've got DNA welders, enzyme blockers, microtubule disruptors, and precision missiles. The strategic application of this massive arsenal is arguably the most complex part of oncology.
It is, and strategic combination chemotherapy is the rule, not the exception. The rationale is highly rationalized based on exploiting every biological weakness simultaneously.
Okay, so first, you use drugs with different mechanisms of action to ensure you are attacking the cell at multiple points in its life cycle.
Right. And second, and equally important, you choose drugs with differing toxicities. This is non-negotiable.
You pair a neurotoxic drug like vincristine with a cardiotoxic drug like doxorubicin.
Exactly. Their dose-limiting toxicities do not overlap, which allows you to use the maximum effective dose of both without causing cumulative organ failure in one system.
You also combine drugs with varying resistance profiles to overcome acquired tumor resistance and drugs with different kinetic specificities, the combination of CCNS and CCS agents.
Let's detail that kinetic difference. CCS drugs, like methotrexate, cytarabine, vincristine, kill only actively dividing cells, primarily those in S or M phase.
So they're best for malignancies with a large fraction of cells in the proliferative cycle.
Right. CCNS drugs, like the alkylating agents, cisplatin, doxorubicin, kill cells at any phase, including resting cells. They're vital for tumors where many cells might be quiescent in G0, but are still malignant.
So the clinical strategy is strategic cycling or pulsing.
It is. It's logical to use CCS drugs in short, high-intensity courses, followed by an interval. This interval allows the non-cycling cells, the G0 reserve, to re-enter the proliferative cycle, making them vulnerable to the next pulse of CCS drugs.
Which maximizes cell kill over time while crucially allowing normal tissues to recover during the interval.
Precise.
But the tumor is fighting back. We can't discuss strategy without addressing the Achilles heel, drug resistance. How do tumors so rapidly develop the ability to evade these complex combinations?
The major mechanism, particularly against many of the natural product drugs, the vinca alkaloids, taxanes, anthracyclines, involves the overexpression of the MDR1 gene,
Which encodes for what?
the P glycoprotein. This is a massive, energy-dependent efflux pump located on the cancer cell membrane. Think of it as a physical vacuum cleaner that actively ejects cytotoxic drugs from the cell as fast as they enter.
So it lowers the intracellular drug concentration to ineffective levels.
Exactly. Overcoming this pump is one of the biggest ongoing challenges in drug design.
So the last crucial element is active host preservation. I mean, since these drugs are poisons, modern medicine dedicates enormous effort to toxicity amelioration. Here's where the intelligence of the total regimen is really on full display.
We rely on highly specific targeted protective agents. We already mentioned the chemical necessity of leucovorin rescue to protect normal tissues from high-dose methotrexate.
And the sulfhydryl compounds are just genius. Misna and acetylcysteine. These compounds, rich in SSH groups, are administered to actively detoxify the excretory metabolites of cyclophosphamide and acesophamide in the bladder.
Preventing hemorrhagic cystitis. It's chemical damage control.
And of course, dexrazoxane, the iron chelating agent, used specifically to block the cumulative damage doxorubicin causes to the heart muscle.
And beyond these chemical antidotes, there is system support. We manage nausea and vomiting with powerful antiemetics, targeting serotonin receptors with ondansetron, dopamine receptors with metoclopramide, often combined with corticosteroids like dexamethasone for maximum effect.
But perhaps the most critical advancement in host support is the use of growth factors.
I would agree. Biological agents like filgrastim, GCSF, and molgraspium, GMCSF, are recombinant human growth factors that are administered to stimulate the production of white cells.
This is a life-saving tool, isn't it?
It is. By accelerating the bone marrow's recovery from myelosuppression, these factors dramatically reduce the duration of neutropenia. This lowers the risk of life-threatening infection and allows the next cycle of chemotherapy to be administered on time. They buy the patient crucial time.
And we revisit some of the adjuncts we mentioned before.
Right. Vigorous hydration is maintained prior to and during cisplatin infusion to flush the kidneys and minimize nephrotoxicity. And supportive adjuncts like thalidomide can address issues like cancer-associated cachexia, while corticosteroids control severe edema or hypersensitivity reactions.
We have journeyed today through an enormous swath of biochemical and pharmacological warfare. We started with the blunt force of the alkylating agents, the deceptive chemistry of the antimetabolites, and the structural sabotage of the microtubule inhibitors.
And then we witnessed the strategic leap to precision medicine, targeted tyrosine kinase inhibitors that silence a single faulty protein, and monoclonal antibodies that enlist the host's own immune system in the fight. The progress from the general poison of the 1940s to today's highly sophisticated scheduling and rescue strategies is truly remarkable.
For you, the learner, the key takeaway is that understanding the specific mechanism, why cisplatin is nephrotoxic, or how MTX stops folate conversion, is only the entry point. The crucial insight is the strategy. Knowing how CCS and CCNS drugs are timed in pulses and how protective agents like Mesna and leucovorin are deployed simultaneously.
Oncology today is less about finding a perfect cure and more about engineering the perfect survivable therapeutic window.
And that leads us to the final provocative thought we leave you with.
While targeted drugs are the future of precision, the continued necessity of using broad, general cytotoxic agents in combination regimens emphasizes the ongoing fundamental challenge of cancer treatment. How far can we push the concept of kinetics, cell cycling, and protection rescue agents to achieve total cell elimination before the tumor develops total resistance?
Because the continuous emergence of resistance mechanisms like that P glycoprotein efflux pump means the field must always innovate.
It must. It requires new combinations and novel rescue techniques just to maintain the status quo. So the question is, what combination of kinetics and precision will finally render generalized toxicity obsolete? Something to consider as you dive deeper into these materials.